So welcome everyone. My name is Shelley Bolton and I am the director of the Center for Vaccine Preventable Diseases at the University of Toronto. I'm also an associate professor at the Dalla Lana School of Public Health and the Department of Laboratory Medicine and Pathobiology at the University of Toronto. And I also work as a scientist at Public Health Ontario. I'm very pleased to welcome you to this webinar on the road to recovery for routine immunizations, lessons from COVID-19, which the CVPD is co-hosting with UNICEF Canada. This panel takes place during World Health Organization's World Immunization Week, Pan American Health Organization's Vaccination Week in the Americas, and Canada's National Immunization Awareness Week. So before we start the webinar, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So just before we kick off, a few housekeeping notes for everyone. After the speakers speak, we are going to do our best to address as many questions as we can. If you could please direct any questions you have to the Q&A function on the webinar. If there are questions that remain unanswered or ones that come up after the webinar, you can email us at cvpd.dlsph@utoronto.ca. And we have closed captioning through the webinar function in English. Instructions on how to view it will be listed in are now listed in the chat. Thank you, Liz. Just keep in mind that it's an automated service, so we apologize in advance for any errors that might be made. So we have two wonderful speakers today. Our first speaker will be Julia Anderson. So Julia is the Chief Executive Officer for the Canadian Partnership for Women in Children's Health, or CanWatch. She has over 15 years of senior and executive level experience in international development, not-for-profits, civil society, human rights, and gender equality. Julia works closely with multiple stakeholders on international development policy-related issues, from Canadian and global decision makers to young leaders. In 2019, Julia spearheaded the shaping of a renewed collective vision by Canada's global health sector that resulted in a $14 billion 10-year investment by the Government of Canada. As the CEO of CanWatch, she continues to champion bold, innovative, and even disruptive approaches to advancing the health and rights of women and girls around the world. Our second speaker will be Dr. Ephraim Lamango. So Dr. Ephraim Lamango is the Associate Director of Immunization at UNICEF HQ in June 2021. He oversees the immunization and vaccines-related work of UNICEF, spanning across 7 regions and over 130 countries. He comes with more than 15 years of national and international experience in immunization, maternal and child health, primary healthcare, and socioeconomic sectors, of which more than a decade is in senior leadership roles. Prior to joining UNICEF, he served as the regional immunization and primary healthcare focal point for WHO Afro and worked with the MasterCard Foundation as advisor for health programs. He was the director of maternal child health and nutrition program of the Ministry of Health and the executive director for the International Institute for Primary Healthcare in Ethiopia, where he led the introduction and implementation of innovative initiatives that enabled the country to continue its success of improving maternal and child health. Beyond the health sector, he worked with the private sector and financial institutions to address socioeconomic needs of young people when he was serving as the founding commissioner of the Jobs Creation Commission of the Federal Democratic Republic of Ethiopia. He was an assistant professor in health management and policy in Mekelle University, Ethiopia, and also served as a visiting scientist at Harvard School of Public Health and Bergen University, where he did research on primary healthcare and community health systems. Dr. Lamango earned his Doctor of Medicine degree from Addis Ababa University and master's degree in health management, planning, and policy from the University of Leeds. And he also holds a certificate in medical education from Cardiff University. He is a national of Ethiopia and speaks English, Amharic, and Tigrinya. So we are going to get started with our two amazing speakers. Julia is going to go first. Over to you.
Thanks so much, Shelley. How lovely to be here. I mean, are we done yet with webinars? The answer seems to be no. It feels like this mode of engaging continues to be an important one. And for me, as much as I have loved the few new recent in-person engagements that I've had, being able to engage in webinars allows us to connect to people and folks who wouldn't be able to come together. So I'm grateful for that. And I really thank the participants and the organizers of this event for pulling this together today on World Immunization Week, which is, you know, if we celebrated all the weeks and things that happen, we'd be cheering all the time. But for me, this is one that sits really close to my heart and the work of CanWatch. So as Shelley said, I'm the CEO of the Canadian Partnership for Women and Children's Health. We are a virtual organization and have been long before the pandemic. So I'm located in Peterborough, Ontario, outside of Toronto, which is the traditional territory of the Mississauga and Anishinaabe people. I've actually had the great privilege of studying at the university here with many elders and community leaders. And in all my speaking remarks, I hope I do justice and honor to those teachings that I've received from the traditional guardians of not only this land, but the land across Turtle Island. And when we're talking about immunization and giving a land acknowledgement, I think it's interesting to note that when the COVID-19 pandemic hit, and we had this tremendous rush and innovation to get to a vaccination, in Canada, the decision was that Indigenous communities would be prioritized first. And I was personally heartened to see this. And I wonder if this is a step, I hope that this is a step towards reconciliation and something that will be repeated, because of course we know that in Canada, the federal government has responsibility for Indigenous health systems, I think, which has been a great hindrance for the most part to the health and well-being of Indigenous people. Those health systems should be owned by the communities that in which they're situated. But this to me was a nod towards a recognition that we need to do things differently across this land. And I think it was notable. So CanWatch, just a quick little snippet of what we do. I am not, as my colleagues on the panel, a doctor or a scientist. CanWatch is an association, a partnership, a collective of all, I say, the smartest people, including the folks, UNICEF, Dalla School are members of ours, and we try to bring together and weave together the expertise of both the people, the folks thinking about these huge global challenges, and the people acting and doing and the work to address these huge global challenges. So of course, COVID-19 was a huge moment for us to think about how are we anchoring any response to COVID-19 in the lived realities of the most marginalized women and children and their communities. And so I'll speak a little bit to that in my reflections that I'll give today. So when we think about Canada's history with global vaccination efforts, I think that it is important to say that vaccination is a place that Canada has played an important role. We're sort of a medium-sized toddler donor. We're not the biggest. We can't make one investment and change the world. We have to work across three things. That's dollars, influence, and action. And I think what we've demonstrated through our vaccine engagement, both when we talk about polio, when we talk about COVID, is that it's only when we're playing all the cards in our pocket, so all three of those cards, that we can really make a difference. We are not in a position as Canadians to just throw money at a problem, because quite frankly, our economy is not a size that we can make a huge dent in a problem through resources alone. We really have to use those soft powers of influence that we have to make sure that we're making the biggest contribution we can. And that's also leveraging the amazing research and brains and medical research and science that's coming out of Canada as well, and giving it a fast track to the global stage. So the Global Polio Eradication Initiative and Gavi as well as the COVAX, are all spaces where Canada has invested. And when we think about this investment, what we're looking at as CanWatch is how is this advanced gender equality in the world? So I think my notes and my speaking remarks, I hope tease out that very specific nuance that I think is often lost actually in the vaccination conversation, because when we talk about vaccines, everyone needs them. It's not just women and girls. It's not like reproductive health or maternal health, in which you really have a target population that is very much women and girls. Vaccinations are something that we all need, but we know that they're predominantly distributed by women and community health systems and whatnot. So Canada's short history, and I had about 1,000 numbers given to me, and I'm going to give very few, but I have all those numbers if anyone is interested. So since 2002, Canada has invested over $1 billion through Gavi, so that's the Global Alliance of Vaccine Initiative, and is a founding donor of the Advanced Market Commitment. So Canada is seen as this anchor donor, I would say, for these large initiatives. And when Gavi comes calling, when the AMC comes calling, Canada generally has shown up. So what you see is since 2002 and over the decades that came next, an increase, a doubling every 5 years, year over year, a bolder increase, a bigger increase. And behind the scenes, when you're an advocate like myself, working with Gavi, what we're looking at is, okay, how far can we push Canada to invest? And that will set a precedent then, as an anchor donor, that sets a precedent for how other donors show up. So if we land ourselves directly pre-pandemic, so the advocacy that took place in the fall of 2019 and early 2020. So we're starting to hear about the pandemic, but it hasn't fully landed. Canada pledged Canadian 600 million to support Gavi's effort to deliver life-saving vaccines to children in the world's poorest countries. This support arrived and was committed just at the moment where the pandemic was disrupting immunization services in the poorest countries in the world. Because, and I'm sure my co-panelists will speak to, people were afraid to go to health clinics. People were afraid to leave their houses. There was all kinds of hesitancy that was what I call health system hesitancy. So it wasn't about vaccine hesitancy or access to maternal health care hesitancy. It was actually just a whole systems hesitancy to engaging. So Canada made this commitment and sort of was trying to decide at that moment, which eggs do we put in which basket? Because what we had was this whole new appendage that grew out of the COVID-19 pandemic called the ACT and COVAX. So this was this new multilateral entity that worked with Gavi, worked with Global Fund, worked with all the multilaterals to try to mobilize funding and resources to go towards getting vaccines, the eventual vaccines, because at that point we didn't have them, the eventual vaccines, and early on the PPE and the other life-saving interventions, oxygen, water, the kinds of things that health systems in poor countries don't have access to. At one point, there was entire nations on the continent of Africa that had two points of access to oxygen, 2 hospitals in the entire country, where someone that was suffering the most severe forms of COVID could go and receive this sort of life-saving treatment that they needed. I mean, this is just wild to think about, right? So the ACT and COVAX was set up in order to try to buttress the worst effects of what was unfolding with the pandemic. But as a donor, Canada's thinking, okay, well, we still have our Gavi commitment, we still have our Global Fund commitment, we still have our, which eggs do we put in which basket? And what you saw is there was sort of a spreading of commitment across those different multilateral mechanisms. Polio eradication. And so much of what I think about is the psychology of why someone would do something. And what's been fascinating to me, polio, the history of polio in Canada is that you have Canada's one of the first bilateral donors to the Global Polio Eradication Initiative. Jean Chrétien, Prime Minister Jean Chrétien, is the first to place polio on the G7 declaration, which is a huge, it's something that means that the whole donor community is going to come back to this issue over and over as part of his leadership commitment to MNCH, maternal newborn child health. Stephen Harper reaffirms, and then Justin Trudeau again sustains and reaffirms Canada's commitment. So you see this real cross-party commitment to polio eradication. And I mean, over 750 million that's pledged over and over again. Okay, so we're coming to the end. We've got polio left in two nations in the world, but we know that we need to, eradication means eradication. And what do we see? We see that it's really hard to inspire political will. We have campaigns called the last mile, the final mile. We're almost there, friends. And the interest sort of wanes and weakens because there's been this repetitive call for more and more and more. And when you have a weakening and a waning interest, and all of a sudden a pandemic hits, what's going to happen? All the energy, the little bit of energy that was left, is sucked into the reallocation of resources for the pandemic. And I think that's really what we're seeing. I also, in rereading the history as I was coming back to think about what I was going to say, I think there's a really interesting parallel here. Paul Martin, Prime Minister Paul Martin, was a polio survivor. There were many people 2 decades ago in this country, even a decade ago, who polio had touched their lives. Polio had directly touched their lives. They had someone in their class who had had polio. They themselves had had polio. How does that keep something in the common psyche? How does that keep something front in mind and generate action? And when we're thinking about COVID-19 and vaccinations for COVID-19, I'm quite concerned about the parallels I see between what's happened in the polio space and what's happening in the COVID-19 space. So as the diminishing impact, as COVID-19 impacts diminish in our own communities, we start to lose the momentum on solving the problem. And I think this is a real challenge for global vaccination efforts anyway, because we don't have smallpox, or I shouldn't say that. We don't have the same sort of exposure, I would say, to the life-threatening diseases that folks in low and middle income countries have. And as that kind of moves away, out of sight, out of mind, we see a diminishing political interest. So to me, it was just a compelling parallel to think about how hard it is for me to walk into the Prime Minister's office and talk about polio, compared to how easy it is at this moment, which I think we will lose, for me to walk in and talk about COVID-19, right? And I think that's a real challenge that's in front of us when we look at all these silos of the global, of Gavi, of COVAX, of the Global Polio Eradication Initiative, and we say, we need to do it all, friends. We need to do all the things, right? And that is not a compelling political message at this moment. So on polio, the only other thing that I wanted to make sure to mention is that, as I said before, the levers that Canada has are influence, which we really saw. That's getting the polio onto that G7 declaration, et cetera. We have our scientists, right, which are really interesting. It was Dr. Farrell, a Canadian woman, who made the scientific breakthrough that allowed mass production of the polio vaccine. Canadian scientists were some of the leaders backing declarations like the Scientific Declaration on Polio Eradication. We had the Rotary Clubs of Canada, who've raised over $40 million to date to eradicate polio. And then we've got civil society organizations like Results Canada, UNICEF, CanWatch, and all of our members who are really advocating and pushing. So when you have all these levers at play, I think the polio example, except for that we're not quite there, really demonstrates what a small country or a medium-sized country like Canada can do. Now, how does this line up? I said I was going to tie this back to the Feminist International Assistance Agenda, or to the impact on the lives of women and girls. And I think what's really important in all these initiatives, which I mentioned at the outset, it is women who are delivering the services in communities. 58%, 78%, 82% of frontline healthcare workers are women. And when we're talking about something like vaccines and people are ripping gender equality out, that's saying gender equality is not relevant in this context, what we have seen through the pandemic and elsewhere is that if we're not equipping women with childcare, with paid salaries for the frontline healthcare work that they do, what is going to happen when communities are threatened by something like the COVID-19 pandemic? Women aren't going to be able to be out there and doing the work that we need them to do, immunizing children, immunizing infants, immunizing their communities from things that are perfectly preventable at this point. So how are we putting this all together? And I will close on this with a few comments about the global impacts of COVID-19 on vaccination and where we need to go from here. So we know, and this will be, I think, well shared, that routine childhood vaccination rates fell to levels last seen in 2005. And if you're like me and you think, oh, 2005 wasn't very long, you know, I remember 2005. Then I think, well, that's the year that I graduated from university. Like, that is my entire life has unfolded. Progress that was made year after year, fought for immunization, for global routine childhood immunizations. We've lost my entire career of progress, you know? And if you put that in the context, 2005 is a long time ago. We should not be seeing the same rates that we saw at that time. Like, we have been fighting this entire time and making gains. How are those gains so fraught? And I think what we've learned about that is that healthcare workers piece. We've learned that the global health infrastructure is precariously carried on the backs of unpaid healthcare workers, right? And that precarity is threatened through humanitarian crisis, will be threatened through climate crisis, and certainly has been threatened through the COVID-19 pandemic. This unpaid care that is the backbone of society is torn apart when communities get locked down and locked in. And I think, you know, there's been some work by the WHO and others on making the link between women's unpaid care and health systems. And I applaud this work. And I think this is the conversation. The conversation about health human resources is the one that we need to be having. Because in Canada and around the world, this is going to be, I think, the biggest threat to our health systems. And if anyone has tried to find a doctor in a rural community, or maybe even, I don't know about the cities, but in rural communities, in small cities outside of the major urban centers, we know this to be true in our own country. And certainly we know it to be true around the world. So budget 2022 landed on my desk a couple of weeks ago. I was heartened to see a commitment to global health. They talked about global health. I was dismayed and disturbed that they referenced something that I fought very hard for, which was the commitment that was mentioned earlier. We called it the Thrive Commitment, $14 billion over the next 10 years. And they referenced this commitment as a commitment to global health. The commitment they made was not one to global health. The commitment they made was to global women and children's health. And for me, the focus on women and children, the spotlight being there on the most precariously placed individuals in marginalized communities, is absolutely critical. And I don't want to see any movement of that spotlight. I think even in the pandemic, this is where Canada's foot should be forward. So what do we need to do? We need to build on the expertise. We need to have more conversations like this. I need more Shelley's and Ephraim's and you folks in my community to make sure this science is getting that fast track to the global stage and to the practitioners who are doing the work. And I think Canada must play that role because, as I said, we're a small donor. This is absolutely critical. We need to maintain the spotlight. We need to pull the spotlight back on where we have committed it to be, which is squarely on women and children. And that the impact of that is, of course, on their entire communities. But this is where we are already falling behind. And in the context of a place we are already falling behind when everything else is getting shoved backwards, it looks like a dark future for women and children in the most marginalized communities. And I don't, for one, accept that. We need to scale up investments. We need to invest in data. I think one thing that we've learned in a profound way is that if we don't have the information and data, we can do very little about that. I mean, even just working on our gender equality work domestically and the government of Canada coming to us to ask who are the players working on gender equality and gender-based violence in communities in Canada. And I'm thinking, shouldn't you know that? Why are you like, shouldn't that be information that you have? It just reinforces everywhere I look this need for national surveillance systems to know who the actors are, to know who the players are, to put them on a map so that we can engage them quickly when we need to. And we need to strengthen research, tech partnerships, monitoring and evaluation, all the levels of different ways to ask questions and get curious. Those need to be investments that Canada is making, not when the pandemic happens, not when the next pandemic happens, but right now. And I think we've seen the impact of letting that slide in a really profound way. So the crisis that we have in front of us right now is not one of problems that we don't have the solution for. The crisis that we see in front of us right now is one of political will and energy. And I think we need to be really clear. We needed a year and a half ago, innovation, we needed research, innovation, thinking, new thinking. We have the tools now to solve everything from polio to malaria. That was another really interesting research or finding that came out in the last couple of years. And COVID, we have the tools. Now we just have to have the political will to actually employ and use them, especially as the impacts of COVID-19 start to diminish. Our kids stay in school after March break, these things happen. And I think it's the role of everyone in this room, as well as the actors like my members, to make sure that that happens and to try to take steps to balance global health priorities in a smart way, but really to integrate in a way, because it's only together and in collaboration, in partnership, that will stop the tide of going backwards and bring it forwards like we need to. That's it for me.
Thank you very much for that, Julia. We are now going to hear from Dr. Lamingo. Take it away.
Thank you very much, Shelley, and good morning, good afternoon, colleagues. My name is Ephraim. I'll be speaking about the road to recovery for routine immunization. I might not be giving you new information other than what Julia already spoke about, but I would simply put numbers and transcriptions to some of the facts that Julia mentioned. And as UNICEF, we work on immunization. We are one of the oldest institutions that have been supporting countries to provide immunization for the last 70 plus years. And we have taken part on historical efforts to eradicate smallpox, and now current effort to eradicate polio and prevention of many of killer diseases of children. And since we are an institution that's established to address childhood health and children's survival, thriving, and development, I'll be speaking about much more routine immunization, which is quite instrumental in reaching more children and saving lives. Next slide, please. So I would like to start by really sharing you some of the disruptions that have been caused by COVID-19. And these disruptions are those kinds of disruptions that are being caused by cessation of services in health facilities, and also closure of some of the services during the advent of the pandemic. And communities weren't sure whether to expect this or that service to be available in health facilities. And they resorted towards staying at home. And given health workers also were not coming to health facilities. So there has been a greater focus on really tracking how this disruption have affected essential service delivery, including routine immunization. And here the graph you see is, to summarize it quite simply, it tracks the progress of service disruption over the last 2 years period, and we call it the PULSE survey, and it's a joint survey between WHO and other partners. And the main intention of this survey is to really understand how many countries are reporting disruption of services on regular basis. So the first assessment was done on the third quarter of 2020, which was the round one that showed a significant disruption to health service delivery due to the pandemic. And also the second one, which is done in first quarter of 2021. But what's worrisome is that the last one was conducted covering the period of the fourth quarter of 2021, and the report was prepared a few months ago. That really showed there is a continued disruption. And the one you see circled by red in here is that there is still a continuing average level of disruption, whereby 44% of countries that have been asked who have actually reported there is a continuing disruption. And what is more worrisome is the around 19% of those countries still report significant disruptions that range between 75 to 100% of services being affected. This spans across preventive services, clinical services, and it spans across all maternal and child health and preventive and therapeutic services as well. Next, please. And this disruption had its own impact on different kinds of services, but particularly the impact is much seen in primary care services, which includes immunization and maternal and child health services. And above all, it has also shown impact on some of the elective therapeutic services, including surgeries, which many of such surgeries have been postponed to prioritize and make sure there is a physical distancing and less crowding in health facilities. Immunization have been impacted on both sides by the disruptions in primary care service and by the disruptions in community care, given it's provided both through outreach services and in health facilities. So as you can see, these disruptions have still continued, and there are efforts to really make sure these services are returning back to normal, and there are some successes that we can report to. Next slide, please. And this disruption in immunization resulted in a significant backsliding, as Julia was earlier speaking, and the moderator also shared some of the key data in here, whereby we have seen a significant decline in coverage of the third vaccine that prevents from diphtheria, tetanus, and pertussis, which has gone back to 83%, which are the sort of the levels we were in some decade ago. And it's quite worrisome if it continues in the same level, because it's usually easy to lose ground, but regaining it back is quite difficult. And we have seen close to 3.5 new children who have become zero-dose children, or children who have completely missed on their first dose of DTP vaccine. And under-vaccinated and unimmunized children also increased to one of record highs that we had over the past few years. Next, please. We have seen a similar context in measles. And as many of you know, measles is one of the largest killers of children because it's quite contagious, and a decrease in coverage will increase the number of children that are susceptible to the disease. And this year, our reports have clearly shown that there is a close to 80% increment, to be exact, 79% increment in the number of new measles cases reported in different countries, as opposed to what we had a year ago. This is a clear sign that there will be likely many more diseases to follow as an outbreak because of the decrease in coverage that has been happening during the pandemic period and accumulation of children that remain unvaccinated in the past as well. So this is quite worrisome going forward for the global health work. Next slide, please. And one of the significant declines in coverage has been seen in, there is variation between regions, and the acronyms you see in here refer to some of our UNICEF regions. And the ones highlighted in red, the LACRO is the Latin American, again, the Caribbean region. And the one you see right second below that is our South Asia region, where we provide significant support. Even though the number of zero-dose children is quite high in the African region, the decrease due to the pandemic has been strongly felt in the South Asia region due to significant decline in India, and also the Latin American in the Caribbean region, which had continued its backsliding, because for the past decade, the coverage in the Latin American in the Caribbean region have been decreasing from year to year, and this has been further worsened by the pandemic as well. India has been doing quite well, along with few other Asian countries, but the significant decline that we have noted over 2020 has shown us that we have lost quite huge ground. Close to 2 million new zero-dose children emerged out of that region. There has been so many catch-up campaigns conducted after that we will see as part of the road to recovery. Next, please. Other than the disruption of routine immunization activities, many campaigns were postponed in the earlier days of the pandemic, which was the result of initial disruptions. Close to 66 countries had at least one vaccine preventable disease immunization campaign postponed due to COVID-19, which at this very moment, close to 2 years after the advent of the pandemic, this has been significantly improving, and 31 countries with at least one campaign postponed due to COVID-19. And at this very moment, it's only 35 campaigns that have been postponed, and 48 countries have reinstated these campaigns. New vaccine introduction also being one of the ones, including human papillomavirus vaccines that were planned to be introduced in several low-income countries have been postponed. So now there is a regaining of that momentum again. Next, please. So we have seen COVID-19 negatively impacted immunization services worldwide because of the overburdened health systems that have been again overstretched due to the service closure and disruptions, and also supply chain being disrupted, whereby vaccines were not available, supplies were syringes and other supplies were also not available in health facilities. And as a result of such lack of services, there has also been erosion of trust and confidence, and there has been increased risk of disruptions in global vaccine availability as well. And this has posed uncertainty in the future. Next, please. But there has been a concerted effort by UNICEF, WHO, and many other partners to closely follow the coverage of each vaccine antigen and really implement a vaccine recovery efforts, immunization recovery efforts. So the graph you see in here really shows you the recovery across each month. This is during 2020, whereby you can see, for example, in the Eastern Mediterranean region or the Middle East and Northern Africa region, in the first 6 months of the pandemic, there has been a significant decline of coverage, but the significant decline of coverage later improved in the latter half of the year. And the regions like the African region had one of the lowest decrease in coverage, but also recovered later in the year. But there are some places such as the Southeast Asia, the Southern Asia countries, including India, whereby the decline have not been met by equivalent level of recovery. This is the one you see in red, where there was considerable decrease in coverage, close to 60% in some places and in some of the months, but the recovery hasn't been as strong as that in 2020. Next, please. So understanding this, there have been so many efforts to improve coverage in immunization, understanding the need to close immunity gaps and the need to recover. But as part of our COVID-19 recovery effort, not only to go back to pre-pandemic levels, but also to build back better. And building back better requires building resilient systems. And the investments are not only disease focused, but they are foundational investments. It requires increasing number of health workers and also training them well. It requires increasing number of health facilities. It requires improving access to basic health services, which are not currently things that you see in low and middle income countries. Next, please. So many countries have implemented so many efforts to recover from the impacts of the pandemic. Some of them implemented service delivery interventions, which spans from providing home-based care to using telemedicine and also integration of services. But particular to immunization, so many catch-up campaigns were conducted. Places like India, where there has been a considerable decrease in coverage, have been conducting catch-up campaigns, reaching up to 83%. So we think they have almost recovered from the impact that the pandemic has caused. And many African countries have also been conducting recovery campaigns. Health worker capacities have been strengthened in many places, including training of health workers to be able to respond to some of the impacts of the pandemic, and also psychosocial support as well. And rapid job training aids have also been developed. And there has been also interventions much more focusing on access to medicine and health products, where there has been procurement of huge surge of commodities. In many countries, one of the critical examples, and we hope that we'll be able to maintain it going forward, is that many countries have recruited additional health workers into the system. Some of them even recalled their retirees. Some of them engaged their health professional students and medical students to even provide vaccination and some of COVID-19 prevention efforts, which can be quite exemplary as we go along forward. Communities have been strongly engaged. They have been taking part in preventive activities and also implementation of proactive strategies to really see how we can really support governments. And health financing strategies have been strengthened in some places, including fee waivers and also utilization of public funds. Next, please. These are some of the final slides I have to do a bit of commercial as well on sharing what UNICEF did in helping these recovery efforts. One of our greater focus has been in closing immunity gap and support the recovery effort in countries. So we have supported all countries that we work in improving demand and supply chain strengthening so that they will be able to do implementation of activities that are focusing on recovering from the impact of the pandemic. So much of the catch-up campaigns in countries have been supported by UNICEF and other partners, including WHO. We're working on mobilizing resources to support immunization, but also health systems along with COVID-19. And we're trying to be a bit inventive in using COVID-19 funding to also strengthen systems so that coverage can remain higher, but while also maintaining vaccination support. Supply chain is our bread and butter, so we're supporting countries in receiving cold chain equipments and strengthening their supply chain systems. Demand is another area of competence for UNICEF, where we have implemented human-centered design, social listening, and also using digital platforms to fight misinformation and to avail information about where vaccines are available, what are the potential side effects, and how communities need to perceive the risk and benefits of vaccines. And we have worked significantly with communities to be able to improve political commitment and the public commitment. And we have used so many ambassadors and champions to encourage people to take COVID-19 vaccine and also safeguard routine immunization. The narrative of the next discussion in the global community is integration. We are encouraging COVID-19 to be integrated into routine immunization in primary healthcare, so that this campaign-based approach of giving vaccines to improve coverage of COVID-19 vaccine is rather offset by encouraging an integrated system. But it requires a lot of investment. And this is where many of the donors and countries such as Canada also come in, along with many other donors, because providing vaccines with the campaign is very easy, but it doesn't build systems. And it would always keep countries dependent. So the very basic intervention now is we increase the capacity of our primary healthcare systems in low and middle income countries so that they will be able to absorb COVID-19 vaccine delivery, which is for adults. And many of these systems are built for delivery of vaccine to children and mothers. So when you increase significant number of adults, then you have an overwhelmed system. So to avoid that, you need to increase number of health workers, health facilities, and also re-engineering of some of the service outlets will be required. And that's where the point comes. And this will need to be aligned with our current effort, as many of you have been hearing about the pandemic preparedness for the next round of engagement whenever there is a new pandemic coming in. Over from me. Thank you so much. I really appreciate it. Happy World Immunization Week for everyone. Every day is a day to speak about immunization, but let's make sure we use this week to really amplify the voice of serving children. Over.
Thank you very much to both of you. Those were two very engaging and interesting talks. I do agree we should talk about immunization every day. I mean, I know I do, but we all should. So now would be the time to ask all of your questions. So if you can please type your questions in the Q&A function, that would be great. And while we're waiting for questions, I have a couple of prepared questions for each of the panelists. So starting with Julia. We have a question here about whether you think that routine immunization has been impacted in Canada. So we've certainly seen a global view in Ephraim's presentation as well during the pandemic. And what do you think about vaccine confidence and the impact of COVID-19 on vaccine confidence in Canada, and how we compare the impact of COVID-19 on vaccine confidence internationally?
Thanks so much for the question. I mean, I'm not a data expert on this. From everything that I've looked at, I was involved in some of the early conversations, high-level conversations about how we were going to address what we anticipated to be the anticipated vaccine hesitancy across Canada. So this again was before vaccines were widely available, and we were already polling and looking at sort of the Canadian population. What we saw was that there was about 7%, and this was cross-referenced between, I think it was 5 different polls at the time, so it was a pretty robust sample. There was about 7% of Canadians who were anti-vaccination, and that they claimed, I mean, we didn't look into this as a poll, but they claimed that they this had played out in their lives. So that means they had already refused vaccinations for themselves or their children. So that was a question to kind of verify if their action lined up with their beliefs. And then there was another whopping, I want to say it was 34, but it could have been 36%, who were saying, we don't know. Like we've vaccinated, we're not against vaccination, but we just don't know because we don't know what, we think it's too fast, the science isn't going to be ready, all these reasons that we've heard time and time again for reasons people are vaccine hesitant. So at that time, we really were trying to design campaigns for that group of people. So we were trying to say, that's a group, that's our target, that's 7%. We hope we can bring some of them in but really we're looking at that 36, 34%, that's the difference between, widespread vaccination and not very widespread vaccination. And interestingly, I think we saw this play out more when it came to vaccination, which we would have anticipated with children than we did with adults. So we saw more parents willing to vaccinate themselves than they were willing to vaccinate, especially that 5 to 12 age group. And again, I'm sure you can speak more specifically to the data better than I can. But I think the answer is we are following alongside those global trends in Canada, right? And I think what we see from the psychology of the population, and certainly I can speak anecdotally to my own family, those who are having to come out and say, join a protest it could be about not wanting to wear masks in a business, all of a sudden they're drawn in to an identity, and so many have done great work. I love Adam Grant's work on the way that beliefs follow identity, right? So they're now part of this crew. And what I've seen is a really interesting, I'm Albertan, and this is played out in my family and in Alberta, and a really interesting mix of sort of the religious right that my family would consider themselves part of, to the more hippies who are kind of more into like the health food movement and things, and a real merger of those communities that have formed a common identity. And that common identity includes being labeled as anti-vaxxers. So where they may not be taking the COVID-19 vaccination, they're pregnant, they're having a child, they have labeled themselves and taken on this identity as an anti-vaxxer, and in fact attended a protest So they're less likely at that point to then vaccinate their child. And this is what we're seeing, right? That once you take on that label and once we label you as such, you're more likely to follow behavioral trends and patterns associated with that identity. So whether that's not wearing masks, whether it's all kinds of things that may not have been the impetus for your original, you were a person who just didn't like the fact that you were locked down, or you were a person who did think that the science wasn't ready, so you didn't want to vaccine, but you were fine with other vaccinations. So I think this is a real problem. And I think the best path forward is actually to remove and start getting into the nuances of people's true complaints. What are their actual concerns, and getting underneath that. I mean, that's the only path to behavioral change. And I think this is absolutely critical, that we stop throwing these people into a lump together of anti-vaxxers when maybe they're anti-maskers, and maybe know what are they actually against, and what is the conversation that's necessary in order to bring them along, and in order to protect them, as we've seen new studies come out recently, and protect the people around them from both COVID-19, but then also the resurgence of perfectly preventable diseases, which Dr. Ephraim spoke to, which I think we're going to see the rollout and after effect of the pandemic.
Thank you, Julia. And actually, on that note of routine immunization, Ephraim, I wanted to talk to you about how to reach every child. So how do we make sure that children who are particularly vulnerable, for example, those who live in emergency settings and who are impacted by conflict, how do we ensure that they're able to maintain their immunization coverage for routine immunizations?
Thanks, Shelley. That's a very important question. And let me start by reflecting on the demand-related issue that you also asked, Julia, which is a very important aspect of reaching children in conflict-affected areas. I think it's important for all of us to see that we shouldn't lump vaccine anti-vaxxers with vaccine hesitants, given that there is so much vaccine indifference, and that vaccine indifference emerges out of lack of understanding. Being an anti-vaxxer requires a good understanding and tweaking the facts or understanding the details of it so that you can use it to make a case. And in many of the low and middle income countries that we operate in, limitation to access vaccines emerges out of not in fact even vaccine hesitance, it actually emerges out of lack of access to the services. And this lack of access to the service, so you can talk about supply and demand, whereby there is a good number of vaccines and amount of vaccines available in the country. There is available demand because if you ask communities and parents if they want to have their children vaccinated because it prevents them from disease XYZ, most of the parents would be happy and would be able to do that. But there lies a very important aspect, which is the way services are organized. If services are not close to families, if they are not close to communities, if the vaccines do not necessarily make it to the last mile, if a health worker doesn't necessarily provide vaccination service on a daily basis, because in many places to open a vial of a particular vaccine, which would vaccinate 10 kids or 20 kids, it would require collecting some cohort of children. And for them to do that, they have to have a specific dates on a weekly basis that tells parents that they can only come twice a week or so to get these vaccines. And those dates might be, market days, that there is an opportunity cost for the parent or for the mother because she has to, forgo an opportunity to generate an income to get service for, immunization service for her child. And there are so many things that come into play. And even though the facilities are close to communities, there might not be trained health workers. And the community mobilizers that usually provide services might not necessarily be vaccinating ones. They will teach you, but you have to go to a nurse or a midwife close by, and you might need to walk 5 or 10 kilometers in areas where there are no transports. So there is a good tendency that we say, oh, people are not getting vaccines because there is no demand, but no. People are not getting vaccines because vaccines are not available close to them, are not accessible close to them, and there is so much opportunity cost, and many of them have to pay, even though vaccines and immunization service are free of charge and they're provided without any payment. But families do actually have a cost to actually come to the facility. So those are the very basics, and this is much more pronounced in conflict-affected settings, whereby the way services are organized is that you don't find regular service delivery points because services have to be provided by either by mobile teams, and it will require us also to re-engineer some of the way we do immunization. In many of conflict affected areas, the areas are not governed by the conventional government. So maybe they are under a rebel group, which would require us as a UN agency to somehow broker a truce to find a humanitarian corridor to let these vaccines pass through and to establish these sites for communities to be accessed. And at the same time, it would also require us to have capability to operate between different countries, given that these fragile settings are cross-border, they have a tendency to be cross-border between two countries, which are less likely to be served. And there are so many intricacies in acquiring vaccines for places such as affected by conflict. But in the future, many of the unvaccinated children will be in middle-income countries, because many of the countries that we have now as low income will transition to become middle income. And they will usually graduate from support from vaccine support, such as given by the Global Alliance for Vaccine, which will be very difficult for these countries to continue to provide vaccines, even though their gross national income improves, which is the critical indicator to identify countries to support or not to support. And the other is there will be many of these children will be in conflict affected settings. So in middle income, conflict affected settings, and hence the need to really re-engineer the way we do business, the way we provide business, and keep in mind, it's going to be expensive, and hence the funding that is required to do so. Thank you so much.
Thank you, Ephraim. So we only have a few minutes left. So as a last question to kind of tie both talks together, can each of you say a few words about women as decision makers for routine immunization? So we talked a lot about female healthcare workers, but can we move inside the home and get an understanding of, in the most high needs areas, who makes decisions for children about whether or not to get immunized, and how can we harness what we know about that as part of the road to recovery? So Julia, maybe you want to start, please.
Yeah, thank you. I mean, I think Ephraim will have more interesting things to say about this, but I would just say that of that 38% of Canadians that we polled that were vaccine hesitant about whether or not they would vaccinate their children or recommend vaccination to others. So those were two of the questions. They were predominantly women. So in that cohort of truly vaccine hesitant, so these were not as these distinctions are so critically important, as has been pointed out, they were vaccine hesitant. And so I think what we do see is that women are making those decisions often, or at least have a high degree of influence over those decisions, but they also bear the brunt of the cost, the opportunity cost that Ephraim was just speaking to, right? Whether it's about them literally rearranging their day in order to get children to these vaccination appointments. It's about them maybe influencing the men in their household in order to get access to the funds to take transportation, or making the case for missing that market day, right? Like you can just sort of see all these different pieces within the home that play out. And so when you have decreasing social pressure in communities because everyone and their neighbor is missing immunizations, I think that really just is going to have a compounding effect. So when entire communities are committed to vaccinations and it's just normal in your household, fine. When you're distrustful of the health system because of COVID-19, distrustful of whether or not you'll be safe to go to that health system, I think this is going to be a compounding challenge, and it's really getting to those women with the messages, with the information in order to allow them to make informed decisions about their children's vaccine status. And also those critical maternal health. I mean, so many things come back to maternal health, but the maternal health visits, right? Like those were where babies and infants were getting their first vaccinations. where women were receiving information about reproductive health and family planning. And so when you see a fragmenting healthcare system that's starting to sort of crumble, like we see in conflict zones, the missing of those neonatal and postnatal appointments have this knock-on effect that's incredibly profound and dangerous. So I think efforts to come back to the basics, we know what works, we have the tools, come back to the basics are really how we get to those women and give them the information they need to make informed decisions. But I'm sure Ephraim has lots to say about it as well.
Over to you, Ephraim. Thank you, Julia.
I do not have much to say other than what Julia said, but I wanted to emphasize that gender roles really play a big, they take a big space in the immunization access. At this very moment, we know 1 out of 5 children in the world are unvaccinated. 4 of them are vaccinated, and reaching the 4 takes less resource than reaching the last child, because the last child is either in conflict affected areas, in a remote rural area, or even in urban but poor areas. And in these contexts, gender and particularly decision-making power really plays a role. If you go to health facilities in many low-income countries, which also varies from rural area versus urban area, and if you follow on a vaccination session, you will see that it's hard to find one man sitting to have their child vaccinated there. It's usually mothers and women who bring their kids to vaccination. Unfortunately, when you go into the distribution of household incomes, you will realize that it's obviously the man who earns in terms of cash and make the decision on the allocation of resources within the household. We all understand money spent in a household, its money is better managed or resources better managed under the woman rather than the men. Because when income of mothers increase, it usually translates to better health, better education of children and thriving of that household, which is not the case when income is hoarded by the men. So even though the immunization coverage between boys and girls is almost equivalent, whereby you don't see much difference, the decision-making power to actually take the 5th child to a facility and get them vaccinated is heavily influenced by the gender-related decision-making roles that are played between a mother and a father, and of course what's expected at community level from the mother. So mothers really shoulder the brunt of really having children to be vaccinated. And as we design our health systems, unless and otherwise we make sure these roles are well reflected and our service structures are also much more close to the way the mother actually spend her day, it's very difficult to offset this decision-making related power interplay between the man and the women. And I think the next leapfrog or the next breakthrough out of reaching the last child in immunization would come out of addressing and accepting these gender-related gaps. Thank you.
Thank you very much to both of you for answering the questions, but also for 2 really informative presentations. And thank you to all our participants for joining today. And we'll see you next time.
Shelley, maybe if everyone hasn't left, there is a question about female community health workers not being paid, which is a critical aspect.
I'm mindful of the time, but like if you can stay and answer it quickly, I think that would be okay.
Yes, and I think it is a very important aspect of delivering vaccine to communities. Mothers tend to have their kids vaccinated much better when the health providers are women. And community health workers do play a big role because they can easily relate to the needs and interests of the community. But the problem is, especially in low-income settings, most of the female community health workers, not only females, but the entire community health workers, are not necessarily salaried. They are somehow incentivized with stipends and paradigms, but they are not necessarily salaried. And that puts an accountability challenge. You cannot expect a community health worker to provide full set of service with whole set of accountability if you cannot salary them. And the bigger question with governments is that when you ask them, why don't you salary them? It's all about, there is no finance to really salary them, even though we know they will be able to advance this. And going forward, I think the biggest success out of improving coverage in primary healthcare would only emerge when we have more community health workers salaried, well-trained, and supported. So it's just to concur with this fact, and UNICEF really advocates and supports community health workers' engagement at community level and works with the governments to be able to find the next country to be able to start a salaried community health worker program. Thanks.
Thank you.